Welcome back to the Film Noir series. In this video, we will cover Neisseria meningitidis, the cause of meningococcal meningitis, the second most common cause of acute bacterial meningitis. By the way, Streptococcus pneumoniae holds the #1 spot. First, let's start with a quick recap. Neisseria are 1. Gram-negative diplococci, 2. Oxidase positive, 3. Glucose fermenters, 4. Growth on chocolate agar, 5. Also grow on VPN, aka Thayer-Martin agar. 6. We see increased susceptibility in C5 through C9 complement deficiency because of lack of 7. MAC complex. 8. Major virulence factors are IgA protease, and 9. Pili that demonstrate antigenic variation. Okay, we now return to our feature presentation. Mac is in search of the lost flame. We join her in the study of General Mater. Pay close attention to everything you see because we've placed all kinds of clues for you. General Mater likes a single malt whiskey. This should help you recall a singular feature of Neisseria meningitidis, maltose fermentation. Remember, both N. meningitidis and N. gonorrhoeae ferment glucose, but only meningitidis ferments maltose. So what makes this bug so pathogenic? Well, for one, their pili allow them to attach to sticky surfaces like the mucus-covered nasopharynx, which they can colonize. Mac's pili-like earring is hanging close to her nose to remind you of nasopharyngeal colonization. Once there, meningococcus can enter the epithelial cells lining the nasopharynx and hang out without causing any problems, or they can spread to the bloodstream and wreak havoc. In the majority of cases, the bacteria stay tucked away inside the nasopharynx quietly, waiting to catch a ride on a sneeze to spread to the next host. This is called asymptomatic carriage. N. meningitidis can outsmart the host's defenses with a protective capsule that prevents phagocytosis. But it can shed its capsule to enter the epithelial cell. With modern science, we've got some vaccines that target the capsular polysaccharides to neutralize this foreign invader. Of course, with one small but important exception, meningococcus type B. Turns out meningococcus type B has capsular antigens that don't appear foreign to our immune system, so it's not all that immunogenic. Until recently, we didn't have a vaccine for type B, so type B infections were a big problem. But the marvels of modern medicine came up with a way. Curious how? Stay tuned. Okay, time for Mac to really lay her cards on the table. Here's the torn ace card representing IgA protease. IgA protease helps bacteria to adhere to mucus-lined surfaces. This is another reason why meningococcus can colonize the nasopharynx. The lost flame. Well, it's still lost, but Mac will get to the bottom of it. Remember, the lost flame represents the all-important virulence factor lipooligosaccharide, or LOS. LOS is a potent stimulator of our inflammatory system. This compound makes our immune system our worst enemy, throwing our hemodynamic, clotting, and metabolic systems all out of whack, which can ultimately lead to septic shock and death. But let's start at the beginning with transmission. And we do believe the general is transmitting some signals of guilt. Just look at those drops of sweat. Let these drops of sweat here remind you that, like a lot of respiratory pathogens, meningococcus spreads via respiratory droplets from close contact. Bacteria enter the body through the nasopharynx. In the majority of people who contract the bacteria, they just colonize the nasopharynx, and these people won't even know it because they don't get sick. However, in a small minority, less than 1%, the bacteria spread and invasive disease ensues. In the right crowd, the bacteria can spread pretty rapidly. Outbreaks have been known to occur in close quarters and confined spaces, like military encampments and college dormitories. So how does N. meningitidis cause meningococcemia and meningitis? To teach you this, let's go through the pathogenesis one step at a time. After the bacteria make their way to the nasopharynx, they establish infection by invading and spreading hematogenously. Once in the bloodstream, Neisseria meningitidis causes a pro-inflammatory response generated by lipooligosaccharide, or LOS proteins. Uh-oh. Seems our suspect has thrown what appears to be the lost flame onto the fire and caused quite the inferno. These envelope proteins are Neisseria's version of LPS, and Neisseria produces so much of it that it outgrows the surface area of the bacterium, and then begins blebbing off, much like these spreading embers here. It's these blebs of LOS proteins that cause the massive inflammatory response. And this inflammatory response leads to vascular injury, including damage to the endothelium, leaky capillaries, intravascular thrombosis, and hemorrhagic necrosis. It's a nasty domino effect that can quickly progress to total deterioration. Just look at these red vines overtaking the fountain here. A rather ominous sign. And they're not the tasty red vines either. You see, leaky capillaries cause a buildup of fluid into the extravascular space. This leads to hypovolemia and shock. In hypovolemic shock, the blood vessels clamp down to try and counteract the hypotension. Also, the inflammatory response and endothelial injury put a call out to platelets to come to the scene. And with all that vasoconstriction, the blood is pretty stagnant, so it clumps up, and the platelets get used up, which leads to thrombocytopenia and thrombosis. Hence our recurring symbols placed here, the fallen plates and stack of firewood. You may see a characteristic rash in this phase, a petechial rash. This is an extremely important finding because it's an indicator of thrombocytopenia. Once those platelets start to clump up, well, you set off the coagulation cascade. But the coagulation cascade runs wild because the clotting factors are getting used up too quickly. So you have a crazy imbalance of clotting and bleeding. A very bad state called disseminated intravascular coagulation, or DIC, and not one you want to roll the dice on. This is a sick patient who needs immediate attention. So if you see the small petechiae evolving into larger purpura or ecchymosis, that's a strong indicator that the patient's illness is progressing to DIC. The mechanism for Neisseria coagulopathy isn't exactly clear, but it is believed that protein C dysfunction may play an important role, symbolized here by Sketchy's own protein C corporal. In fact, replacing protein C could potentially treat severe meningococcemia. The capillary leakage itself can cause shock, but there's another disease process happening in the adrenal glands that can accentuate the shock, and it's called Waterhouse-Friderichsen syndrome. Hence our recurring WF water tower we've placed here. When the body is under such stress, the adrenals need to kick things into high gear to pump out cortisol, our stress hormone. To meet this demand, the blood has to pump through the adrenals, so the pressure in the adrenal vessels goes way up. Unfortunately, the adrenal vessels aren't well equipped for such high pressure, so the blood hemorrhages out into the adrenal glands. It's not the hemorrhaging itself that makes a big dent in the shock state, because blood loss is pretty minimal. But in Waterhouse-Friderichsen, the adrenals can't function properly. The resulting adrenal insufficiency further contributes to the shock and is very often fatal. What's a telltale sign that the adrenals are shot? Well, you see a mixed bag of some pretty deranged metabolites, represented by this mixed bag of snacks. Look for hypoglycemia due to insufficient cortisol, and hyponatremia and hyperkalemia due to low aldosterone. Meningococcemia can occur with or without meningitis, but once the bacteria are inside the bloodstream, they can spread across the blood-CSF barrier through the cerebral capillary endothelium or choroid plexus, all leading to meningitis. Hence General Motors' meningitis mohawk statue. But wait, there's more. Even as people recover from their illness, they can have other inflammatory sequelae, so-called immune complex-mediated complications. You may see things like pericarditis or arthritis. The mechanism isn't very well understood, but these are very important complications to be aware of. So, what does N. meningitidis look like clinically? Well, it starts with more of a viral-like prodrome that may mimic other common infectious illnesses like the flu or strep throat. Check out the general's stylistic choices to learn more about the signs and symptoms. Nonspecific symptoms of fever, malaise, headache, nausea, and anorexia, and upper respiratory symptoms are common. Of course, he'd have a flame bandana. Muscle aches can occur with the flu or other viral illnesses, but they are much more intense in meningococcal illness. Sore throat, again, is a common nonspecific symptom from a virus or strep throat. Oftentimes, the doctor may test for strep, which comes back negative, but keep a high level of suspicion for meningococcus, because it can quickly progress. As the bacteria spread to cause bacteremia and sepsis, meningococcemia, signs and symptoms are more alarming and worrisome. Characteristically, the rash is a petechial rash. Small petechiae can quickly progress to purpura or ecchymosis, which is strongly suggestive of DIC. Remember to look for signs of septic shock, and don't forget about adrenal insufficiency, which worsens the shock state. Remember, meningococcemia can occur with or without meningitis, so you don't want to miss this. Neisseria meningitidis is actually the second most common cause of acute bacterial meningitis. The presentation of fever, headache, and neck stiffness are indicative of meningitis, hence the neck brace placed on the statue. If an LP is done, look for high protein, low glucose, high white cells, and gram-negative diplococci. As patients recover, they can have immune complex-associated conditions like arthritis, pericarditis, pleuritis, or vasculitis. Diagnosing N. meningitidis requires a high index of clinical suspicion. You don't want to miss classic signs like the petechial rash. A lab workup, including CSF analysis, can also be helpful. Don't delay. Get cultures and start antibiotics ASAP. A third-generation IV cephalosporin that can penetrate the CSF, like ceftriaxone, is most frequently used, but penicillin will also cover you. If the patient is allergic to penicillin and other beta-lactams, chloramphenicol can be used. Of course, this character would have some chloroform stashed away. Careful there, Mac. Since this infection is easily spread by airborne droplets, it's important to give close contacts post-exposure prophylaxis. Hence, we've added Sketchy's own PPX shield here. Close contacts are defined as someone who has had over 8 hours of close contact with the patient during the 7 days prior to onset. And the drug most commonly used for this is rifampin, hence the rifampin rifle. But IM ceftriaxone or ciprofloxacin are good choices too. Thankfully, we now have vaccines to prevent all important types of meningococcal infection, including serotype B. The quadrivalent vaccine, represented by these 4 syringe shooters in the liquor capsule, contains the capsular polysaccharides of 4 serotypes of meningococcus. The conjugated vaccine gives an extra boost to the immune system. In the conjugated vaccine, capsular antigens are linked to a carrier protein, the diphtheria toxoid. Yep, it's dipped to produce a stronger, longer-lasting immune response. The vaccine against serotype B consists of recombinant proteins, which are proteins found on the surface of the bacteria. Remember, the vaccine is indicated for 10 or 11-year-old children with booster shots around age 16. Most colleges will require it to live in the dorm. Keep in mind the special patient populations for whom the vaccine is critical, like those without a functional spleen are more susceptible to Neisseria infections, and those with deficiencies in terminal complement factors, since they can't make the membrane attack complex. That's right, Mac's working 5 to 9 to get the job done. That's all for meningococcus. Don't go anywhere because we still have a few surprises up our sleeve. Has Mac really closed the case on the lost flame? Stay tuned for part 3, Neisseria gonorrhoeae.